I'm Jamil Asaria, and I'm a facial plastic surgeon based in Toronto, Canada. Today I'll be demonstrating a case of FUE, or follicular unit excision hair transplantation. Our patient today is a perfect candidate for FUE hair transplant. He's 49 years old. This age is actually a very good age for hair transplant, as the hair loss pattern is starting to stabilize very nicely, and we can very clearly see the areas of recession and have a better idea of prediction of future hair loss as we go forward. Over the last 20 years, the patient's been experiencing a gradual hair loss, starting mostly in the frontotemporal regions and then involving the frontal area and crown area. He has good donor density in the back of his scalp we'll be harvesting the grafts from, and he already has a fairly good hairline pattern and some light coverage of hair in the regions that we will be reconstructing today. These types of patients tend to get an excellent result. The other feature that's beneficial for this patient is the texture and the quality of his hair. His hair is wavy in nature, and it's a brown color that doesn't have a lot of discrepancy between his skin. By that I mean the hair color and the skin color are fairly close, which provides us a better appearance of density. The waviness as well gives us better coverage than somebody who may have very straight hair. And finally, his hair caliber, or the thickness of the hair shafts, is quite good. It's not extremely thick, but it's definitely not super thin, and that again gives us more density. The other thing that will determine his outcome is really the type of graft we harvest from the back, which we'll be able to tell later on. By that, I'm talking about the quantity of hairs per follicle that we harvest. Every patient's a little bit different. Some patients have a lot of singles, some patients have a lot of doubles, and some have a lot of triples and quadruples as well. Of course, the more hair we have per follicle, the more overall density we're going to be able to provide for the patient. Today's case will start by, we already started with preoperative photography, which is very important for all these cases, for referencing afterwards and comparing the result, oftentimes a year from your actual procedure date. He's also been given some preoperative medications. We generally start with oral Keflex or cephalexin, some Ativan to help the day go by a little bit quicker and smoother for the patient, as well as a medication for pain such as Tylenol. So that's already being given. The next step of our procedure will be to shave the hair down. For follicular unit excision, we need the back of the scalp shaved down to a level 1 in order to harvest the hairs. We'll be harvesting from a broad region at the back of the scalp. Because we're already shaving the back, most of the time we'll shave the front of the hair as well. If a patient is really resistant to shaving the front and they want to keep the length, we can work around the hair in its native kind of length. So we'll get started with the shaving portion and go from there. The most important part about designing the hair restoration is marking out the frontal hairline. We're fortunate that our patient today is in his late 40s, and at this stage the hairline starts to stabilize, so we're able to more accurately predict where the hairline is going to go in the future. It's important to remember that any grafts that are going to be placed along the frontal hairline are going to be permanent. Therefore, as the patient ages, the hairline will not recede or migrate further back. At the same time, we expect that over time patients are going to lose hair behind the frontal hairline. So we want to be very conservative, particularly when we're designing a frontal hairline for a younger patient who may have early frontotemporal recession. The first step in designing the frontal hairline is designing the mid-frontal point. That's the point right at the center of the hairline. The mid-frontal point is designed to lie approximately between 7 and 11 centimeters from the glabella, or superior portion of the eyebrow. This can vary from patient to patient, and the other consideration is the rule of thirds of the face, where we like a semi-balanced space between the forehead and the glabella and the bottom of the nose to the chin. So we're kind of putting both of those into thing. Now, we can see that he has a retained frontal forelock. It's a little bit thin and it's a little bit sparse, but he does have retained hair here. Sometimes we'll see patients with no frontal forelock whatsoever, and that's when it's very important to pick our spot accurately to design a natural hairline. I'm going to measure his natural point where he starts with his first row of hairs, and we can see that's right at about 7.5 centimeters at his superior brow, which is a great distance. So we do not want to bring this frontal hairline down. Remember, many young patients will start to recede a little bit here early on and desire a hairline that's brought back to where it was in their perhaps early 20s. We really want to avoid this because it's something that's very difficult to correct later on if we're trying to catch up with an area that's been grafted too inferiorly. So we'll measure that and mark that first area out as the mid-frontal point, which will lie right over here. The next part of our frontal hairline will correspond with the frontotemporal angle, or the apex of the hairline. And this is an area that we will be restoring today. We can see that over time with hair loss progression, he started to migrate his hairline inferiorly and lose a lot of hair in the apex region of the frontal hairline. What this does is not only does it make the forehead look larger and make light penetrate more through into the scalp, but it also gives us less central hair to comb either to the side or back, thereby making the whole density of the frontal hairline look diminished. When we can broaden that hairline out, we have a lot more hairs to comb back or to the side, thereby framing the face in a much more effective manner. One of the rules we want to keep in mind when we're designing the frontotemporal line and picking the spot of our apex of our frontal hairline is to ensure that this apex is not too low. When we look at it from the horizontal, the apex should always be sitting on a vertical axis higher than the mid-frontal point. So it should be sloping this way. If you start to see it go this way or lower down, you've made a mistake in your frontal hairline design. How far laterally does that go? Approximately, an approximate measure we often use is straight vertical from the lateral canthus, or a centimeter lateral to the orbital rim. We'll kind of go up from here. Again, this will vary from patient to patient. So you'll see me marking this out several times to pick the right spot, because it will really define where we're going to be transplanting behind. One other consideration we want to think about in the frontotemporal receded area is that if we bring this hairline very low, we're going to be using a lot of grafts. If we're grafting into an area that already has some hair in it, we're going to need less density. But if we bring this down, and also the frontal hairline down, each millimeter that we bring it down is going to be a very graft expensive area where we're going to be using a lot of grafts, and therefore will not have as many grafts for the posterior restoration. So if we can keep it a little bit tighter, we're going to have an overall denser result for the patient. Again, one of the things I usually start with is following the patient's natural hairline if it is in a good position. We like to keep it just beyond these few stray hairs. It's nice to have these little few stray hairs anterior to the hairline. That makes the result look even more natural. So oftentimes I'll start with just a very rough kind of hairline that I'll pencil in. I like to use a wax pencil so that I can change it and kind of accommodate it as I go side to side. I can also show it to the patient before marking the final position of the hairline and make sure the patient's in agreement with what we've marked. So we'll start with kind of a rough hairline following some of his natural hairline, and we'll bring it side to side. Then we'll decide on the frontotemporal junction, or the angle, and then we'll look at what we're going to do in the temple, and I'll talk to you about that part next. And I like to see this from several different angles. I'll often lay the patient back at this point and look at it from the top to see symmetry. And I like looking at this from above and then kind of having the patient sitting up, and it really gives us a little bit of a different perspective as we're working. This is going to mark the kind of most anterior most portion of our transplant. As we come back here, Sometimes we'll design a flare into the temporal hairline. Sometimes we'll keep it just straight across as we are here. If we do design a flare, oftentimes we'll like to design a flare into kind of the margin where we've already marked to blunt this area a little bit. When we look at the temporal hairline, this is called a temporal point out anteriorly here. He has a very natural temporal point that's at a good distance from his brow. If we can avoid transplanting the temporal region, I like to try and avoid it. That's because we know that this hairline will start to migrate posteriorly. If we put too coarse or too thick hairs that don't match this fine temporal hair, over time that area can look unnatural. So if we don't need to restore the temporal area, try to avoid it as best as possible. We will maintain somewhat of a receding frontotemporal recession like that for a natural pattern for someone of his age, but also for a natural pattern of somebody who's in their 50s or 60s, because as we know, this hairline is permanent. So I don't like to square this off too much. I like to keep some recession. We are going to bring all of this area forward to again broaden the overall width of his frontal hairline. So I'm going to measure this line again. We're right at about 7 centimeters now, right to the top of his brow. Then I'm going to measure out here from his lateral canthus. We're about 9 centimeters. This should be 9 to 11 centimeters. Again, as a rough measure, I have a few measurements in my head. So if I look at it and say, well, how come that's 8 centimeters? I know there's maybe something I got to check one more time. And that's exactly 9 centimeters on this side as well. So that's good symmetry. We can see he has a little bit more loss on his left side than his right side. And his hair naturally parts in this direction. Typically, the direction the hair is parting in will have more loss. We also require more grafts in that area because the hair is falling away from us rather than over that area. So this is a fairly straight across hairline that we've drawn for him without any flare. By flare, I mean sometimes we'll bring this area inwards to kind of bring in and accentuate that frontotemporal recession. But because he already has good hair in this area, I think we can create this slightly wider, broader look for him. The next thing I like to do is just transition it into the temple hair. As I said, I like to do as less as possible because if you imagine if we put grafts out here, as he loses this hair, you can already see this hair is fine to start with, and then that area is going to continue to thin, and he's going to thin here. So we don't want a hairline that's out here, and then he loses hair behind it, and we see an obvious front line. So we'll avoid that as best as possible. Sometimes I will, however, just blend it in a little bit to the temporal line like that, and we'll do the same on the other side, and we'll measure to see if we have symmetry. Remember, patients' faces aren't always perfectly symmetric, so don't go 100% by exact symmetry of measurements, but also continue to look at the patient back and forth to make sure it's the ideal spot. We're at 7.5 centimeters on that side, and we're at about 7.7 on this side. So we'll look at him sitting forward. I'll bring this a little more forward like that. So then I'll make little minor adjustments once I've drawn kind of my base hairline to ensure good symmetry for the patient. And this part really, it's worth spending a little bit of extra time on this part because it's critical. Once we start the transplant, once there's local anesthetic infiltrated, once there's some edema, it's very hard to tell where the exact hairline is precisely. So if we spend a little bit of extra time at this point, it's well worth it. Chin down a bit for me. Let's go ahead and chin back up. And it's also good to see kind of just step back from the patient and look at it from several different angles. I'm going to come around to the other side. Good. I like that. I feel like that's a very nice natural pattern. So before I mark it out, I'm going to show it to the patient and discuss with the patient why I'm doing what. Again, it's all about managing patients' expectations. Sometimes they may want a much lower hairline, and we'll discuss with them why we've selected this and have them be in accordance with it. I mean, can I see a mirror next? So this is the hairline I planned for you. We're going to use your natural starting point right here. We're going to be grafting inside this border that I've drawn. Right now, your hairline goes back like this, right? So we're going to be bringing all of this downwards this way to give a much wider frame here rather than this narrow frame that we're seeing. And then we're going to add density all throughout. So you're a little bit thin. Even in the hair that you do have here, we'll be adding density all throughout here. Once we shave it, we'll have a much better idea of where the grafts are going to lay. But we can see all this area. This front part is going to take up most of the grafts. Because there's no hair here, we're going to have to put a lot of grafts. Back here, you already have here, so we're going to be doing much less dense. We're going to need less grafts as we work back, okay? The lower we bring this, the less grafts we have for the back, because this is going to suck up a lot of grafts. So the tighter we can keep it, the better and the more natural. I think this is a nice natural pattern too. It's not too far forward. I think this will look very good over time, okay?
It stays within the family line too, right?
That's it, yeah. See, that's another important thing. Like he said, your grandfather had good hair here. It was receded at the back, but it was good here and had the same shape. So again, that's why it's always important for me to talk to the patient. People have different ideas of what they think looks right for them. All right, the next step in designing the hairline is creating a natural appearing hairline. So we've drawn the boundaries of the area we're going to restore, and now we're going to draw the actual shape of the hairline. When we look at, we can even look at his natural hairline, although it's thinned and receded a little bit, so it doesn't have a lot of density. But notice how it grows with, first of all, some stray hairs that are anterior to the hairline, but then that it grows with macro irregularities. That means it kind of undulates back and forth a little bit, and then lots of micro irregularities. So the hairs don't just come out in a straight line; they come out, anterior, posterior, and they're irregularly irregular. That means it's not just kind of a same similar pattern, but it's changing as we go forward. So I like to keep that in mind as I'm designing this line, where we're altering and changing kind of the pattern as we go forward, and we'll also be changing the angle as well. Later on when we're implanting, we'll talk about changing the inclination of the grafts as we go across, but for this part, we're just trying to create more of an irregular hairline that's going to be the anteriormost portion of the area we're restoring. And typically patients will have a little bit more of irregularities laterally rather than medially. So again, I like to look at the patient sitting up. I like to see them from the horizontal aspect. Kind of that way I have them chin down, really to ensure we're creating the right pattern for that hair, because this is a permanent hairline. Again, when it's too aggressive in a young patient, it's very problematic. We have a more middle-aged patient, and we have a conservative hairline that's going to work very well, and it's going to add a lot of density. When we grafted this area in and beyond it, it's going to create a much richer and fuller appearance for the patient once the grafts are grown out. All right, so prior to harvest of the grafts from the follicular unit excision sites, we will be icing and anesthetizing the area. I find that ice really helps with anesthesia prior to administering the local anesthetic. Again, this typically is the most uncomfortable part for the patient, so we want to make it as comfortable for the patient as we can. I find ice helps to numb the area a little bit as well as distract a little discomfort. The first thing I'll do is I'll take a 30-gauge needle, and this is local anesthetic with an even mixture of marcaine and lidocaine, and I'll raise small wheels just kind of along the periphery of the border where we're going to be harvesting from. We're going to be doing basically a field block all the way across here. And I find this tiny needle really is tolerated very well for the patients. So we'll start with small amounts. Following that, we'll use a 27-gauge needle on a larger syringe to help get local all the way across this area. I find this way really minimizes discomfort for patients. They almost don't even feel that little pinch with a 30-gauge. And remember that the local anesthetic is buffered with sodium bicarbonate solution to decrease the acidity in the solution. So far, we've used a total of 3 cc's. Typically in this area, we'll use a total of 40 cc's of local anesthetic. As we mentioned for our other case, we want to keep in mind the possibility of local anesthetic toxicity during the course of the day, as we are injecting a significant amount of local anesthetic. However, it's spread out over a large period of time. One of the things that we keep in mind is if there ever is a complication related to local anesthetics, for everyone on our team to know where all our supplies are to start an IV, start administering fluids, have ready access to benzodiazepine, as well as intralipid. All right, so that was done with a 30 gauge needle. Next, we're going to do the same thing with a 27 gauge needle. So we're injecting the same local anesthetic solution. It's a mixture of 1% lidocaine with 0.25% marcaine, and it has fresh epinephrine mixed into a total quantity of 1 in 100,000. We also put a little bit of triamcinolone or Kenalog into the mixture, both in our tumescent mixture as well as our local anesthetic mixture, and this helps to minimize edema postoperatively. The depth of our local anesthetic infiltration is really at the deep subcutaneous level, right over the fascial layer where the nerves and blood vessels are. We should kind of just see that area distend very easily. There should be very minimal resistance to injecting the local anesthetic, which decreases the patient's pain, but also gets the local in the right layer. If we see that our needle is too superficial, something like this, where we're seeing resistance and we're seeing kind of almost the dermis inflating up, that's really not going to provide good, deeper anesthetic for our field block. So it is a little bit deeper than that. The needle should pass easily, and the local should tumesce that area very easily as we go across. So far, we've used a total of 15 cc's as we've gone across here. And again, we'll probably use a total of anywhere between 30 to 40 cc's on average, sometimes a little bit less than that. So we've injected a total of 20 cc's so far, in addition to the 3 cc's that we put in right in the beginning with a smaller gauge needle. That back area is going to feel very numb. It's going to feel kind of almost like got a pillow on the back of your scalp that you can't feel very well. Next, we're going to inject a little bit of tumescent fluid. The tumescent fluid is saline without any local anesthetic in it, but with epinephrine mixed into a concentration of 1 in 75,000. So it's a little bit stronger dose of epinephrine than the local anesthetic itself. We're going to be careful in the quantities that we're using, and we'll only be injecting it in the direct areas that we're working in at a time. When we start the harvest, we're going to be starting in the central region of the posterior occipital scalp. So that's the area we'll tumesce. When we're just about completed the harvest in this area, 7 to 10 minutes before, we'll move laterally and inject in that area. For FUE harvest, we've selected the most dense portion of hair-bearing area in the occipital scalp. We're careful to avoid areas that may succumb to further recession over time. We don't want to go too high up on the crown. His crown right now starts quite superiorly, but over time it may migrate inferiorly, thereby exposing the area where we've harvested the grafts, and also giving us the risk of taking grafts which may recede or fall out over time. Anteriorly, we're roughly corresponding to an area that corresponds with the posterior surface of the helix. If we need more grafts, or it's a secondary session, or we need a lot of grafts during one large session, we can bring that anteriorly. If we are bringing that anteriorly to the supraauricular area, we want to again ensure that it's not too high. We also want to ensure that harvest out laterally is not as dense as centrally. When we're harvesting from this area, again, it depends on how many grafts we're doing per session. In this session, we're aiming for 2,500 grafts. So we've designed a broad area. The broader the area is, the less we're going to diminish the density when we're taking the grafts from that area. It's said that an area looks fairly normal until over 50% of the hair follicles in that area are either lost, or in this case, harvested. So we know that we can safely take 30-40% of the hairs without making the area look a lot thinner. When we're harvesting, we're also not harvesting an equal number of grafts throughout the region. We're harvesting more grafts centrally and then progressively less grafts, because the hair gets thinner laterally. It also gets thinner inferiorly. So our density of harvest is going to be the highest here and then be more interspersed as we get out to the periphery. For us, we're roughly planning on harvesting, if we break this into fifths, to take about 600 grafts from the middle fifth, 500 grafts from that intermediate area, and 400 grafts from the lateral-most fifth that we're harvesting from today. So that we're going to keep that in mind. Prior to harvesting the grafts, we've already added local anesthetic as well as tumescent to the area. Next, we're going to inject just plain saline. So this is just normal saline solution, and this adds extra tumescence to the area. We'll inject a total of anywhere between 3 to 9 cc's per area that we're working, and this just expands the space between the graft and the subcutaneous tissue. So it allows us to harvest and take that graft out a little bit easier. So the first thing is we want to be in a comfortable position. We want to be with our arms at a kind of a 90-degree angle. We're wearing loop magnification as we're working here. If you're harvesting, you want to be wearing loops anywhere from 2 to 4 power. I think the more power, the better. Today I'm using a 3 power loop. We're going to examine the area of harvest, and we're using a foot pedal to kind of operate this motorized FUE punch. There's a variety of different punches. The one I'm using today is called the WOW, W-A-W, DeVroy punch. I don't have any financial interest with the company, but I really do like this punch. I have a variety of different punches that I utilize. I have several sharp punches. I also have Harris's safe punch, which is a bell punch. What I like about the WOW is, number one, it's very reliable. We've had this punch in particular for several years, and it's worked very well. But what I like about it is the mechanism of operation when we engage the drill. It's not a circular motion coring the FUE graft. Rather, it's an oscillating motion. So that drill bit is oscillating back and forth. This minimizes our transection rate greatly. The second thing I like about it is that the tip, or the biopsy portion of the punch, it is fluted at the end. So it's got kind of a trumpet shape with the sharp edges on the outsides. This also, again, minimizes transection of the grafts as we're harvesting. The harvest technique itself is dependent not only on our right hand holding the punch. A lot of the work, like most surgery, is done with our left hand. So we've tumesced the area underneath the harvest site. We're holding the punch in a comfortable position. We're examining the exit angle of the hair follicles. And this changes throughout the scalp. It changes from superior to inferior. It changes from medial to lateral in terms of the bevel that the hair is coming and exiting the scalp. When we engage the punch, we want to ensure that we're coming down, right down parallel to the hair follicle. If we're too acute or we're too shallow an angle, we're going to transect that hair follicle rather than coming and coring it out. The other thing we may do, if again we're at the wrong angle, is push it. Even if we don't cut the hair follicle, we may push it, or what's called burying the hair follicle down. When a hair follicle is buried, it then presents as a cyst later on, several weeks to months later. So we'll start by looking at our first few grafts. We take the first few grafts slowly because we're going to examine the angulation. We're also going to examine the depth of the punch. If we're too shallow, my assistant Ming here is going to have difficulty extracting the graft, and he's going to strip some of the soft tissue surrounding the hair follicle. If we're too deep, it's going to bury the graft, and even if it doesn't bury the graft, it's going to cause more bleeding because we're at an area that's below where we want to be. So our first few grafts, we're going to just examine. I'm going to work with my technician to kind of look at each graft. When we take the graft, it's rather than a punching motion, we're not punching the grafts out. I always kind of talk about we want to extract the graft. So first we want to engage the graft on the epidermis. We want want to go through the epidermis and then slowly parallel hug that graft and slowly bring that graft out rather than punch it out. When we punch it out, it pushes it in. So we'll look at the first two grafts and see the quality of the grafts, the depth of the grafts, the angle of the grafts. We'll kind of start in this mid portion that I've already two-messed. So there's our first attempt at a graft, and Ming will bring that out. We can see the graft. It's got epidermis and dermis at the top. There's the hair exiting, which we've cut short. There's the hair shaft and the bulb there. Compared to the FUT grafts, the grafts have less fat surrounding them. They're thinner or skinnier grafts in general. Today we're using a 0.9 millimeter punch. The punches that I utilize range over 0.8, and I have 0.9, 0.95, 1, 1.05, and 1.1. This varies depending on the patient. Depends on the types of grafts we want. For example, for an eyebrow, we want very skinny, thinner grafts. If a patient is multi-hair follicles, a lot of 3s and 4s, we may need a 1.1. Here, this is about average, and 0.9 is kind of my average punch that I'll be using. So again, our first few grafts are going to be slow. We're going to look at the angle, we're going to look at the depth, and we're going to look at the quality of my first few grafts. And I'm watching my assistant to see how much is my assistant struggling to take out the grafts. Are they coming out easily? Is it difficult? So really the first ones are kind of getting our bearings when we're starting. So we can see several grafts here. This is a 2 follicle hair graft. This one has 3. We can see 3 little bulbs. There's another triple there, and here's a single. So we have a variety of grafts, and we'll be sorting these. We're counting and sorting the grafts as we go forward. So we're going to continue harvesting now in linear fashion. So we kind of have a bearing now of the angle that the hair is exiting at. And I'm going to start harvesting. Sometimes we'll get stuck in your punch like that. It's important to stop and just have your assistant extract them from the punch. If they're blocking the punch, you can use a little 27 gauge needle and clear the punch. Like I have a little bit of soft tissue in there now. Thanks. Once we have a good idea of the depth, the skin quality, how much force we need to put on the punch, we can start moving at faster speeds. Generally, we want to work in linear fashion, skipping grafts as we go. We want an irregular pattern as we go. We typically will harvest at a rate on average of about 500 to 600 grafts per hour. We can get, even depending on the patient, even up to 700 or 800 grafts per hour. Speed is really by efficiency in terms of where you're harvesting from and how you're working with your technician. So I'm trying to stay out of Ming's way. I'm working kind of in a linear line, and I'm just marching forward. Out of the corner of my eye, I'm watching what the grafts are looking like. I'm also watching to see if he's struggling to extract a graft. Are they coming out smoothly? Is he having to pull at them? Are they popping out? So there again, we'll look at those grafts. Those are pretty grafts. They have nice soft tissue. They're very parallel with the hair shaft. They have an equivalent amount of soft tissue around it. If you look at this one graft in particular, can you lay that one down for me? We can see this was actually a triple. You can see that right at the end, this hair right here where my pointer is, I transected part of that multi-follicular graft, so slightly off the parallel in that one particular graft. As we work inferiorly, we can see that the hairs are much finer. They tend to exit at a little bit of a shallower angle, and the depth of the hair shafts are a little bit more shallow as well, so our punch is a little bit more superficial as we come through. It's typically a little bit harder to harvest these lower hairs, but sometimes we'll go a little bit slower. We also have to be careful that we're not too far inferior at the inferior border of the hairline. We're in an area that may recede. So we're spacing out our graft harvest in this area a little bit more than we were in the mid portion of the occiput. Here's where we're harvesting a lot of the single hair follicles that are finer that we're going to use for the frontal hairline. These will be a very good match for the hairs of the frontal hairline, especially in that transition zone right in the frontmost border that we designed for him. I'm going to demonstrate again the technique for harvesting FUE. We're going to stabilize with our left hand. Our right hand's resting comfortably. We're going to parallel the hair follicle and enter through the epidermis and go through soft tissue. And we're going to extract gently each graft. And I can see that I had a little bit of trouble pulling that graft out, which tells me I need to go slightly deeper than what I did for that one. So a little bit deeper and see if that makes it any easier for him to extract, and that does. So I modified my depth slightly. Again, we don't want to go too deep. If we go too deep, you're going to have a high rate of burying grafts. This portion of the procedure takes anywhere from 2 to 4.5 hours, depending on how many grafts we're harvesting. Usually we'll break for lunch after the harvest is complete, and then we'll start the implantation part of the procedure. The grafts are being sorted by our other technician in terms of size of grafts, that means number of follicles in each follicular unit, as well as the quality of the grafts, which we're going to use differentially in the different areas of restoration later this afternoon. As I'm harvesting kind of a component of single follicle hairs, doubles, triples. I'm trying to create a variety of grafts depending on the area we're restoring. For example, if we're just doing the crown or vertex area, which is rare to do in isolation, I'll be harvesting mostly multifollicular units. If I'm doing this for an eyebrow restoration, I'm trying to harvest mostly single follicles. Here I'm trying to get a pretty broad distribution of different types of hairs. Once you have kind of a good system in place and good assistance, you can harvest, on average 500 or 600 follicles per hour. And that's usually a very acceptable rate to do a 2,500 FUE case in a day. Is pretty tolerable for both the surgeon and the patient. So we're approximately an hour and a half into the harvest thus far. We've already harvested the central fifth of the posterior scalp, and there we were harvesting at a density of approximately 600 grafts per fifth. We're now spacing the grafts out slightly more than we were in the central area, but still this is a very dense region. Again, that can vary from patient to patient. He has excellent density throughout almost all of his donor region, so we'll continue to harvest at a very similar graft ratio per square centimeter. At this stage, we've approximately harvested about a third of the total number of grafts that we'll be using during the session. We'll continue to migrate across the lateral aspect of the scalp, and then we'll turn the patient into a more sideways position to harvest on the other side. So we've harvested at this point 2,400 grafts. We're getting our last 100 grafts from the lateralmost portion of the harvest site. On average, we've harvested a density of about 15 grafts per square centimeter. We can take a look at the harvest site thus far, and you can see that our harvest pattern is what we call an irregularly irregular pattern. We never tell patients this is a scarless technique. What it is small punctate scars. If a patient wears their hair even out of blade 1 or definitely blade 2, that hides very, very nicely. If a patient bicks, like razor blades their hair down, they may see small white punctate scars for sure. So it's not scarless, but it's not a linear scar, it's small punctate scars. Again, we're using a 0.9 millimeter punch today for this case. These last grafts that we're harvesting from closer to the temporal region now as we transition from the occipital region are finer, and you can see they're kind of skinnier grafts. We'll use these grafts along the frontal hairline just beyond the transition zone, as well as in that temporal region where we're transitioning from the frontal to temporal area in the frontotemporal recession portion of his frontal hairline. So this is the typical appearance of the donor region after harvesting 2,500 grafts. We've harvested from a broad area of the scalp with a density of approximately 15 grafts per square centimeter. That will leave him a lot of room for future hair transplants. Patients are told to kind of keep this area lubricated with some Vaseline or some polysporin ointment for a few days. It tends to be really sealed and not as weepy and much drier by about 48 hours. A bandage will be applied at the end of the case to protect this area overnight. This area tends to look quite good at the 10-day to 2-week mark, whereby there's really very minimal signs of the graft harvest because the hair in the periphery has grown through as well to help blend it in. Patients are warned that this area may look a little patchier than it eventually will be because a lot of the surrounding hair follicles may go into an anagen or a shedding phase. So we may see an area that looks a little bit lighter or thinner than it will be due to simply just the harvest. So we've just completed the harvest of the 2,500 follicles, and we'll be bandaging this area up, applying local anesthetic to the frontal region, which will be the recipient site, and go for there. This is typically the time after bandaging this that we'll stop and have lunch both for the team as well as for the patient. All right, so the second half of the procedure, now that we've completed the donor harvest, is planting to the recipient area. We had pre-marked out the frontal hairline based on his existing frontal hairline, his mid-frontal point, as well as the areas we had selected to correspond with a natural temporal recession. We can see that we brought his apex back from his natural sort of higher and more acute apex to one that's lower and a little bit shallower angle, but one that will still look natural over time. We're going to restore during this procedure his frontal hairline as well as a portion of his mid-scalp region. When we're restoring these areas, we want to be cognizant of what type of grafts we're placing in the different regions. Each graft, in terms of the number of hairs per follicular unit, is going to have advantages and disadvantages. The frontal first centimeter of the hairline, kind of this area bounded by the dotted line, is what we call the transition zone. The transition zone are those first few rows of hairs, maybe the first centimeter to centimeter and a half, where we're transitioning from no hair growth to a hopefully nice and dense frontal hairline. We don't want that frontal hairline to be overly dense right away. When we look at a natural hairline, it kind of transitions in. So our maximal density will actually be approximately a centimeter behind that frontal transition zone or a frontal line. In this area, we'll be planting only single follicle hairs. So everything in front of this dotted line will be single hair follicles planted. The direction of the hair follicles will match his natural direction that he's planted right now. We can see he has a natural part in a wave that goes towards his right side, and we'll follow that. The angle of inclination is quite acute in these regions. We don't want the hairs emanating out at a 90-degree angle. We actually want them coming out at a nice shallow angle for a natural result. Particularly when we transition into the temporal regions, we want the hairs almost coming down parallel to the skin in this area. If the hairs are coming out at a more shallow angle, they look very unnatural. We'll also be planting some of our finest hairs that we harvested from the lower part of the donor site, single follicles into this region. We can see his natural hairline here. We'll transition into the natural hairline, and we're going to come back to about the mid-scalp portion. Many times the patient will want restoration of multiple areas, and frequently they'll ask for their crown to be transplanted at the same time as the frontal and temporal regions. Sometimes this is possible. If there's minor loss in the frontal and temporal region, and we're just either adding minimal density or slightly increasing or actually decreasing the size of the forehead, then we have lots of grafts to distribute. In a case like this, where we've harvested 2,500 grafts, as a very rough measure, the inner part of my hand or the inner part of my palm is about 1,500 grafts. So when we look at that, we see that's about 1,500 grafts right there, and then we have 2 subsequent sides on each side, which is going to take the remainder of the 2,500 grafts we have. We always prefer to create a fully restored area with optimal density rather than having 2 or 3 areas with suboptimal density. It never looks good when there's multiple thin areas. The patient's not going to feel confident wearing their hair in that pattern. With this type of a pattern with density here, where hair will be able to be styled, combed, and transitioned to his natural hairline, he'll have an excellent result even if he decides not to restore his crown. If he did decide to restore his crown, this would be done in a future session, and for a patient like this, he would require approximately 1,500 to 1,750 grafts. So when the number is around that number, 1,500 to 1,750, if we were to sacrifice, say, 500 grafts from here and put them here, you're really not going to have much impact. So we always counsel patients to try and restore 1 or 2 areas rather than trying to cover everything at one session. And if we are going to do 1 or 2 areas, we want the frontal regions prior to the vertex regions ideally. So there's a lot of innervation of the scalp, especially the frontal scalp, including the supratrochlear, supraorbital nerves. There's also contribution from the zygomatic nerves over here, the preauricular components and postauricular components for the temporal regions. I find that the bulk of the anesthesia really in the frontal area is well controlled with a block of the supraorbital and supratrochlear nerves. So I like to start with that. We apply ice to the region, and then we're being careful that we can palpate his notch pretty clearly. We're being careful that we're not injecting into the artery, and we're depositing a very slow bolus of 1 cc of our same local anesthetic mixture in this area. That's put in very slowly, and then the needle is advanced immediately to the supratrochlear nerve, and that area is also given approximately 1 cc of the local anesthetic mixture. The patient's warned that they may have a heaviness around their eye area, and their eyelids also may feel a bit heavy, but again, with a little bit of icing, that's very well tolerated. Put it right over the top part of your eye. Once that feels cold, let us know, and I'll put the same amount of freezing on the other side. Okay, you can take that away. I'm palpating for the supraorbital notch. It's right over here. It's aspirated back, and we put about 1 cc of the mixture of lidocaine and marcaine in this area. The needle is advanced medially, right to the medial edge of the brow where the supratrochlear nerve emanates from, right at the level of the periosteum. All right. We let that sit for approximately 2 to 3 minutes at the very least before starting to anesthetize the frontal hairline. So we start to get some numbness up kind of up through here in your forehead, and it'll start to come up higher in a second, okay? The part that will not be frozen is the part out here, so you will feel me as I get out to the sides a little more, okay? So we've allowed a few minutes to lapse between administration of our local anesthetic to the supraorbital supratrochlear nerves, and we're going to be injecting local anesthetic directly to the frontal hairline. I feel the blocks really help minimize discomfort as we go across. This will block perhaps the central 2/3 of the frontal hairline as we go lateral. That area will still be sensitive and we may have a little bit of slight discomfort, but we work from an area that's already anesthetized, and then we'll come back to that area to minimize any discomfort from the needle. All right, that should be the most of the discomfort you have today. You shouldn't really feel much. It's going to start to feel really, your whole head's going to feel like there's a helmet around it. That'll take a few minutes to take effect. I'm going to put a little bit of tumescent in that area next. And next we'll inject a little bit of tumescent directly in the area that we're working. We're going to be working along the border of the frontal hairline first. So implantation of the grafts is going to start with a stick and place technique. This technique employs the use of a needle. In this case, we're using a 20-gauge needle to make several small entrance sites which are comparable in size to the diameter of the grafts. A stick and place technique employs the use of the needle and creation of a small entrance site, and then direct implantation of the graft right after creating the little tunnel for the graft itself. This is in contrast to a technique whereby we may make all of the insertion sites right from the start. The advantage of a stick and place technique is that the channels for the grafts are extremely small. They do not need to be widened or dilated at all. The small entrance sites allow for a more snug fit for the grafts. The disadvantage to stick and place is that it is more technique dependent, and your technologists need to be very proficient in creating the insertion sites, but also in terms of calculating how many grafts they're using. Because we're inserting grafts one at a time and just proceeding from one area to the next, we have to be constantly thinking about how many grafts we're using and how many grafts we want to use in different areas. When we create all of the recipient sites right up off the bat, we're able to calculate that right out of the front, and it is not so much dependent on your technicians. We will complete the stick and place technique across the entire frontal hairline border so that we can very accurately maintain this border that was drawn at the starting part of the case. As the forehead starts to swell and as our markings start to rub off, it can sometimes become difficult to maintain that perfect line that we created in the beginning. So we're using a 20-gauge needle to create insertion sites which are in the right angulation and the right depth. If the channel for the graft is not deep enough, we'll have difficulty inserting the graft and the graft will be loose. If the insertion site is too deep, we'll have increased bleeding and increased edema related to the procedure, which we would like to minimize. So our implantation along the frontal hairline starts with all single hair follicle grafts. These were previously sorted during the harvest, and all of the singles are kept separate from doubles and triples and 4 hair follicular units. They're being planted one by one at the correct angle and the correct inclination, as well as depth. You can see how when handling the hair follicles, they are grasped very carefully. The hair follicle is comprised of an isthmus, infundibulum, and an inferior portion. The root of the hair bulb, is at the inferior portion, and we never want to traumatize the hair bulb or its supporting tissue. We also take care not to strip any of the connective tissue around the hair follicle itself. To avoid crush injury, the hair follicle is grasped very, very delicately, and it is delicately inserted into the recipient site. There should be no resistance. We're also careful that the hair follicle is not bending upon itself as it is inserted into the recipient site. It is important to have a team of technicians that are skilled at this very meticulous and critical portion of implantation. So we're well into the transplantation phase, into the recipient site of the frontal scalp area. Just to review what we've done so far, we've transplanted the transition zone along the frontal hairline with single or 1 hair follicular units all across. That density within the first centimeter to centimeter and a half is approximately 25 grafts per square centimeter. Beyond that, we started to fill in the frontal region from side to side with a dense packing technique of approximately 35 grafts per square centimeter. We filled in almost all of the frontal region now, and we're working into his natural frontal tuft. Remember, this patient had frontal hair, but it was a little bit sparse and thin. We're working in the frontal area at bolstering the density that he already has here, as well as working in the mid-scalp region now. In these regions, we're interspersing the grafts a little bit more widely, and we're grafting approximately 15 grafts grafts per square centimeter. The grafts in the front were all single follicles. In that first frontal region where we were densely packing, we were using mostly doubles. We use doubles in this region because we want to pack the grafts as tightly as possible. If we're using larger grafts like 3 hair or 4 hair follicular units, it's harder to get that same density. And it can also look a little bit more unnatural. So we use smaller grafts along that front part. Now in the back, we're using more 2s, 3s, and 4s. One of the other considerations that we keep in mind is how densely the grafts are packed. There's a finite limit to how close the grafts can be put together. When we exceed a grafting density over 35 to 40 and beyond 40, we start to get decreased graft survival as there isn't enough intervening supporting tissue and vascular supply. And furthermore, the grafts start popping up. When we start planting them too close together, they start to dislodge and push each other out. So there is a finite number and a sweet spot even in dense packing. As we continue to plant in the frontal tuft region where he already has some pre-existing density, I thought I'd take the opportunity to discuss the stick-in-place technique in a little bit more detail. As you can see, we're now transitioning to a 19-gauge needle in this region. The size of the needle or the size of the entrance hole that we're creating corresponds to the size of the grafts. Along the frontal hairline and the frontal fringe where we're using only singles, we're using a smaller entrance hole created by a 20-gauge needle. We've now transitioned to a 19-gauge needle to create slightly larger insertion sites. The technique involves sticking, which means using a needle to create an entrance hole for the graft and then planting the grafts individually. This can be done either as a 2-person or a single-person technique. We tend to use a single-person technique. Some pearls of the stick-in-place technique are to use properly trimmed grafts. So the grafts, if we're doing FUT, we want to make sure there's not a lot of accessory fatty tissue around the grafts and that they're a nice uniform shape and size. In FUE, of course, this is already predetermined for us and is dependent on our skill of harvesting as well as patient factors. We want to ensure that the incision size is matched well to the graft size. If the incision is too small and you're trying to stuff a larger graft into it, the graft will either be bent or will pop up and not stay in good position. We're doing this generally under magnification so that we can see clearly the insertion angle of the grafts as we're going in. We typically will use a little bit of a zigzag or staggered pattern as we're inserting, and we're using very fine, delicate forceps. When we look at it closely, we can see that the grafts are being handled very carefully. These grafts are consistently placed in an iced saline solution, as we're already almost 2,000 grafts into the procedure, so the grafts have been harvested many hours earlier. We want to prevent desiccation of the grafts. In terms of handling of the grafts, we really want to ensure that we're not damaging the hair bulb, and therefore the grafts are held very, very gently, and the bulb of the graft is never handled. You can see that our technicians are keeping the graft and the insertion site in the same field. You don't want to be reaching across. You don't want to be changing your field of view constantly and reorienting. You want to keep that field of view in focus for you the whole time. The grafts are also organized. So we have the grafts organized in singles, doubles, 3 hair and 4 hair follicular units so that we're not constantly searching for the right type of graft in any place. And then we're developing a nice rhythm as we're going on. So the advantages of using a stick-in-place technique are that overall, during the length of the case, there tends to be less bleeding. We're making smaller insertion sites and those sites are not all open at once. We tend to have some bleeding every time we create an insertion site, but then that bleeding is plugged off by insertion of that graft. Also, it's much less incidence of having piggybacking or missed areas where we've created insertion site. That means if we create all the sites ahead of time, sometimes certain insertion sites are missed as we go through, or piggyback. That means 2 grafts are put in the same insertion site. There's much less chance of that. There's also smaller incisions and thereby theoretically less trauma to the area, and we're able to follow the angle of the graft very accurately with the needle itself. We can also adjust that incision site as we go along. So we haven't made 100 or 200 different incision sites and then determined that they're slightly too big or slightly too small, and I feel like it's a little bit more of a relaxed position for the assistant itself. What are the disadvantages? There's definitely a larger learning curve for the technicians. There's a little bit greater demand on the physician's time to be present for all of this, and we're really implanting one site at a time. We can't have multiple sites with insertion sites and then people planting as a separate team. It's really an individual process as we're going through. We also have less control over the pattern and design, whereby we're working on the go in terms of where and how many grafts we're putting in. Again, this takes more experience from your technicians and it's more experience from your overall team. All right, this is the completion of our procedure after implantation of 2,500 grafts using an FUE technique. Our patient really was a very ideal candidate for hair restoration. He had focal hair loss that involved his frontal forelock, his frontal hairline, as well as frontotemporal recession that was going back. He's also losing some density in the mid-scalp region, and we've transitioned the grafts from front to posterior. He's going to get an excellent result. Patients like this will get a very good result when the restoration area is focused to a certain well-circumscribed regions. He also has fairly good match of his hair color to his scalp, and he has good hair quality with wavy hair. So we would tell this type of patient to expect really a very definitive difference in hair density and framing of the hairline for the entire face. You can notice that the grafts are already starting to get quite secure in position. The grafts are held, especially these first anterior most grafts, we can see are held by the small scabs around each graft. The grafts get more and more secure day by day. For the first 48 hours, the patient will be instructed just to spray this area every 15 to 20 minutes to help debride a little bit of the dry blood and to keep the area moist. At 48 hours, the patient will be allowed to wash the hair with soapy water and to pat it dry with a towel, but to avoid any rubbing of the scalp or any direct shower to the scalp at all. Normal showering, hair washing, shampooing can be resumed at 10 to 14 days. The patient will exhibit quite a bit of edema in the forehead area. He's dressed with a pressure dressing around the front of the forehead, which will help. He's also given post-operative medications, including low-dose prednisone for 3 days. The scalp is dressed posteriorly in the area of the donor region, and this will be removed by the patient the following day. Most patients can return to work within about a week to 2 weeks at the most. We do tell them to expect some edema for sure in the forehead and possible periorbital and infraorbital ecchymosis, which can occur slightly later, even at day 4 to 6. Other than that, the patient's instructed to take it easy and not do any heavy lifting for the next 2 weeks, and the patient will be seen in follow-up in the clinic at the 2-week mark to give them the green light to really proceed naturally with their regular activities. In this series, we covered the 2 most common and predominant types of hair transplantation in modern hair restoration, that being follicular unit transplantation with strip technique and FUE or follicular unit excision technique. Neither technique is superior to the other. Really, there's disadvantages and advantages to each one, which we use selectively for our patients. In today's transplantation world, I would say in my clinic, about 80% of our patients undergo an FUE technique. The advantages being a slightly quicker recovery time and certainly slightly less pain in the donor region. The advantage of avoiding a linear scar, which is important particularly to patients who are younger and who may in the future decide to wear their hair much shorter than they currently are. However, the strip technique is also an excellent technique, and I really do recommend that for patients who have more mature hairlines and who are really never going to wear their hair short. The grafts yielded are excellent in quality, and it really is the gold standard for hair restoration. We can produce more grafts in a shorter amount of time, and we can really size and pare the grafts down to a beautiful size and shape, which is advantageous for procedures such as beard transplantation or eyebrow transplantation, where the quality of the grafts is imperative. So we use both techniques in our clinic on a routine basis, and we really cater that procedure for our patient. We educate them on both options, and we go forward from there. Hair transplantation is an excellent adjunct to any dermatology, plastic surgery, facial plastic surgery practice. It's one of the fastest growing procedures in aesthetic medicine today, but I would caution you that if you are going to enter into hair transplantation, it's very important to have a consistent team. As you can see through the series of procedures that we did in this video series, a lot of the procedure is dependent on the skill of the technicians. The take rate, the quality of the implantation, transplantation really depends on that experience. It makes the whole experience better in terms of quality, but also smoother for the clinic, faster for the patient, and a more efficient process overall. Hair transplantation is, again, an excellent procedure with very high satisfaction rate. Patients are very happy with the results of their outcome, and today's transplantation techniques produce an extremely natural outcome. When planning hair restoration, remember the key pearls of trying to focus restoration to certain areas of the receding hairline. Select patients who are ideal for the candidate. Don't transplant patients who are way too early on in the hair loss stage. Don't try and cover too large an area at one time. Focus your restoration, do it in 2 stages if necessary. It works better than sparse reconstruction over the entire scalp. Thank you very much for joining us for this series. It was my pleasure inviting you to see the procedures. If you have any questions or any considerations you wanted to share with me, I'd be happy to chat with you. Please reach out. Thanks a lot. I'm Jamil Asaria from Toronto, Canada.